Now we have three types of signals. The first one is low number of signals, somewhere between 2 and 15. One of the things that changed is that surgery used to be a low signal, 5. Now they went up to 15. There are a couple programs that have gold and silver, and examples of that are anesthesia, dermatology, and OBGYN. And then there's large signal programs, orthopedics, ENT, neurosurgery. Now what you'll see is a little bit of a pattern. ENT, ortho, neurology, they're all super competitive surgical subspecialties. Not a lot of people are applying compared to medicine and peds and general surgery. So they can be very specific what they want, and they don't have as many candidates to interview. So a high number of signals allows them to have a lower number of total applicants. So what lessons can we learn over the last 2 years of signaling based on, again, I'll say it, crappy data? One is that signalers experience a higher interview rate. Non-signalers can still get interviews, but it's at a lower rate. Signalers have substantially higher interview rates. So the first group that I talked about was small number of interviews, so small number of program signals, like internal medicine. In large number of signals, orthopedics, ENT, neurosurgery, signalers have a substantially higher interview rate. Non-signalers almost see no interviews. And then in the two-tier system where there's gold and silver, gold signals boost interview rates the most. Silver signals help, and no signals have the least impact, okay? So let's take a step back and remember what we're talking about here. So if you have a small number of signals, you have to use them wisely, and if you use them, they help. If you're in a large signal match, then you absolutely have to use your signals to get an interview, because most of the programs are using that to screen out applicants. If it's two-tier, gold needs to go to the places that you really want to go to, and silver is going to help, but not as much. Now, from your side, you have to, this is Latin for know thyself. You have to be honest in this process. Just like when we deconstructed our program, we had to really be honest about who we were. Is University of Arizona Tucson like Yale or Harvard or Johns Hopkins or UCSF? No, those are hyper academic programs. They're looking for a very specific thing. In the case of surgery, they're looking for the next generation of surgical scientists. You have to recruit people who have a not just an interest in surgery, but an interest in research as well. Our program here is an academic program. Most of our residents will do a fellowship. Almost all the residents will do research, but it's not the be-all and end-all for everybody. Not everyone in my program is using residency as a way to get a fellowship, and fellowship as a way to get their first job so they can get an NIH grant. Some of my residents will, but not all of them. Some of them will go into the community and be just clinical beasts taking care of patients, and we are very happy with that. So what we try to do is offer support for residents to go into whatever career we want. We don't define them. We don't put them in a box. We let them choose and then support them. Now, from your angle, you have to understand who you are and what you bring to the table. You have to understand your application honestly, understanding what pink and red flags you have, and then you have to know what kind of program you want to go into. The other part is you have to understand how competitive the match is for the specialty you're choosing. So here's a little bit of data from the match services. So on the left side, you see all applicant data. And then this one focuses on US MD seniors and US DOs. IMGs, understand, and I don't mean this in a terrible way, it is much harder for an IMG to match than a DO. And it is much harder for a DO to match than a USMD. That's just what the data says. I'm not making this up. This is what the data says. This is the game that you're playing, and you have to embrace that so that you can use the match to your advantage, okay? The other thing this graph talks about is your best chance of matching is while you're a fourth-year medical student and applying during fourth year, okay? Your odds of matching go down after a prelim year. Your odds of matching go down further after a prelim 2 year, okay? So you need to put all your eggs in one basket now so you can match as a fourth year. And then understand that if that hasn't happened, you have to use the odds of you matching and not reach for programs that you're never going to get into. You need to lower your expectations, and you need to focus on getting a spot. So let's talk about some tips to how to navigate this. As I said, the applicant's job is to know what the ideal residency there is for them. If you want to be a massive academic and get NIH grants and get a K grant, then you need to go to a residency that will start you on that path early. And if you go to a program that's a community program that offers great training, it may not prepare you for how to become a great researcher. And the opposite is true also. Going to a hyper academic center and a person wants to be in community medicine, it may not be perfect for you. You may not want to spend 2 years in the lab. Okay, that would be wasting 2 years that you could use on a fellowship. So you have to understand what you're looking for, right? Write your own mission statement and vision statement so that you know exactly what you want. Who are you? What are your goals? What qualities and characteristics are you looking for in a program? And then apply this. This is the most important slide of the day. You have to learn the rules of the game and then play it better than everybody else. What does that mean? You have to put in a massive amount of work. You need to go online. You need to do research and see how competitive your specialty is. The NRMP, AAMC has all this data. You got to look for it. Then you got to look and research the programs. What are the chances I'm going to get an interview, right? There are programs, and I'm going to talk about surgery, but this is true of medicine, pediatrics, rad-onc, anesthesia. It doesn't make a difference. There are programs that are not going to take DOs. I hate to say that because I'm a DO. There are programs that are not going to take IMGs. It breaks my heart to say that because I have a ton of friends who are colleagues and that we trained together who are IMGs and didn't have the same opportunities that I had and certainly didn't have the same opportunities that my wife had, who's an American grad, MD, okay? See if they've ever taken people who have backgrounds like you, okay? If a program's never taken a DO, is there a chance that you could be the first one? Absolutely. You know how I know? I was the first DO surgeon ever hired on an academic path at Yale, okay? But it meant I had to work twice as hard. Look to see if programs have matched similar residents compared to your application in their program. And then ask the question, who do they take? Do they only take American MDs? Do they take DOs? Do they take IMGs? Do they take foreign-born IMGs or only American-born IMGs? What's the average step score? And most programs will give you this data. And the NRMP has data on this as well because we have to fill this out every year. Is it a research-centric program, and is that something that you want? At the end of the day, I told you this is a game. Learn the rules, and I'm trying to give you some of the rules, and be smarter about it, okay? A signal means more to a program that doesn't get a lot of signals than a program that gets tons of them. If you don't like living in a particular city or a big city or a small city or a rural area, if you don't like the weather there, etc., but the program's great for you, be careful. You're going to be spending 3 to 7 years there. And if you signal and you do well on an interview, the match may send you to that program. So be careful when you apply to programs in areas that you don't want to live or in programs that you don't want to be at because there's a chance you might match there. Don't waste signals this way. You have to align your signals with risk tolerance. Don't waste them. If you don't have a perfect application, you can use the signals to amplify your application, but don't overreach. You'll be wasting them, okay? Show love to safety programs. Have a backup so that you know you're going to match, especially if you don't have a perfect application. I'm going to say this again, over and over again. Know the rules and play smarter, okay? Have a realistic understanding of your application. Sit down with someone who's not your dean and who's not your academic advisor and go through the application. Or ask those people, I want you to be brutal. I want you to look at my application and tell me with honesty how strong an application I have. How many red flags do I have? Did you fail step 1 and have to take it again? Huge red flag for a lot of programs. Do I have pink flags, right? Am I a DO? Am I an IMG? Did I not honor my specialty that I went into? I'll tell you for surgery, my faculty, anyone who doesn't honor a high pass, they have serious questions about whether or not they really want to do surgery. I personally don't, because a lot of third years, they don't know if they want to do general surgery yet. And then they get the bug, and I look at how they do on their sub-Is, because that means I've made the choice to go into this field, and this is how I really love and show how much I want to be here. But for some programs, they can't report the grades for your sub-Is by the time the applications come out, okay? I think you should have a backup plan. is a prelim year away for you to get into a program? Is a research year before you apply worth it, especially if you're applying to programs like ortho and urology or dermatology, where they're hyper competitive matches, and you may not have a perfect application. Research helps bulk up your application. And we know that the best chance for you to match is while you're in medical school. So maybe you take a year off after third year, do your research, bulk up your application, and then apply for those hyper academic programs, and you're using the odds in your favor. Okay. Maybe you want to apply to more than one specialty and have a backup. Now, this can be risky sometimes. You have to have 2 personal statements, and you should have recommendation letters from the specialty you're trying to get into. Okay. Again, my example, plastic, CT, and vascular. You apply for those matches, and then you apply for general surgery also. So you have a backup path to get into those specialties as a fellowship. Be careful dual applying at the same hospital. Most program directors don't talk to each other, but it's possible, okay? Especially if you're a medical student in that school and you're applying to general surgery and vascular or emergency medicine and medicine, okay? It's less dangerous if you're applying to other programs, because programs don't really talk that much. But if you're in the same hospital, there's a possibility, so be careful. Don't be afraid to reach. Don't give up on your dreams. That's not what this talk is about. What I'm asking you to be is realistic, and then have the reach, have the dream program, but just don't put all your eggs in that basket. So last slide, I promise. Use your preference signals smart. They're best spent on programs that you're qualified or overqualified for. There's no geographic. If you want to apply to a program where you don't have a geographic connection, so say you grew up in Tucson and you want to apply to a program in New York, this is a way to tell program directors that you want to be there, because there's still some hesitancy with people who don't have a connection to the area. Why are they interviewing here? Are you qualified for the program, but the interview isn't certain? This is a way to express interest and could maybe potentially help you get noticed in a program where you may be slightly underqualified for. Should we align our geographic and preference signals? It probably doesn't matter. Geographic signals do not have the impact that preference signals do. I'm an IM applicant. Is it worth applying to programs that I will not signal, or if they are outside my geographic preference? Again, geographic preference, probably not that important. Look, if your application has a pink flag, and I hate to say that being an IMG is a pink flag, but it's a disadvantage, then your signals are your best way to get interviews. It doesn't mean you won't get an interview. It means you have less of a probability of getting the interview. And that's really important to remember. Does it matter if I choose no preference for geographic preferencing? I think it doesn't matter. It really doesn't. The data says it doesn't. Geographic preferencing is nice, but it doesn't give you the leverage that preference signaling and doing sub-Is do. And just for you all, doing a sub-I at a program, the only thing that shows a higher correlation to matching there is matching into your home program. The next step down is doing a rotation at a hospital, because it shows the program that I have a limited number of outside rotations and I love your program so much that I'm going there. So using sub-Is and electives is a really great strategic way for you to get an interview. It's also a 30-day interview. It's not 15 minutes with the program director, right? You're at a program for 30 days where you get to interact with attendings, nurses, program director, other residents, so that they can tell the program director how great you are.